I welcome you to this lecture where I'll be explaining the approach to the treatment of type 2 diabetes and the status of oral antidiabetics in the treatment of type 2 diabetes. Oral antidiabetics are indicated only in type 2 diabetes. For example, metformin is indicated only in type 2 diabetes because in type 1 diabetics there is no insulin, and for metformin to act some amount of insulin has to be present. Let us take the example of sulfonylureas, again, which have to be used only in type 2 diabetics. Sulfonylureas require at least 30% functional beta cells to produce their insulinemic action. The same thing holds good for dipeptidyl peptidase 4 inhibitors. The same thing holds good for GLP-1 receptor agonists. Pioglitazone also requires basal level of insulin for it to produce its insulin sensitizing action. Hence, oral antidiabetics are indicated only in type 2 diabetics. They are of no use in type 1 diabetes mellitus. Another important point is these oral antidiabetic drugs can only supplement diet and exercise. They cannot replace or substitute dietary management and physical activity. So, the cornerstones for the treatment of type 2 diabetics is not just the drugs but also dietary management and physical activity. Once we diagnose a person with type 2 diabetes, first and foremost educate the patient about this particular metabolic disorder. This will make the patient more responsible towards himself. He has to take the responsibility for his diet, for the physical activity, and for compliance with the treatment. Treat the comorbidities: hypertension, dyslipidemia, obesity, and cardiovascular disease. Please note, like diabetes, hypertension, dyslipidemia, and obesity are also risk factors for macrovascular complications of diabetes like myocardial infarction and stroke. Screen the patient for diabetic complications. Do a fundoscopy to rule out retinopathy. Screen the patient for nephropathy. Screen the patient for albuminuria. Do the serum creatinine levels. Send the blood sample for blood urea and nitrogen. Examine the patient for any neurological abnormalities to rule out neuropathy and assess the vascular condition. This is because type 2 diabetes is asymptomatic in nature. The person may be having this condition long before even he was diagnosed with diabetes. So it is mandatory to screen the person for diabetic complications. This will give us an idea about the chronicity of the condition. Start treatment with metformin. We should not delay the treatment with metformin because metformin has a lot of advantages in type 2 diabetics. It has got prognostic benefit, it has got outcome benefits. Metformin reduces not only microvascular but also macrovascular complications of diabetes. It promotes weight loss. It has excellent efficacy. It can be used along with any injectable antidiabetic like insulin as well as along with other oral antidiabetics. The incidence of hypoglycemia is least or even absent with metformin. So these are all the things, and not to forget, metformin promotes beta cell health and retards the progression of beta cell failure. All these factors make metformin the first line drug in the treatment of type 2 diabetics. Invariably, it has to be used except for those patients who have contraindications for metformin or those who do not tolerate metformin. Once we start metformin, our target should be to get the glycosylated hemoglobin levels to less than 7%. If this is not possible, then you have to add a second oral antidiabetic drug, and the preference is given for sulfonylureas. Why? Because these drugs are also having very good efficacy. They are quite well tolerated, and they have a convenient once a day dose or maximum twice a day dose. Which sulfonylurea to use? From the second generation sulfonylureas, glimepiride seems to be the best because it has got a very strong extra pancreatic action. Even with glimepiride, if the response is not there, you can choose any other sulfonylurea. Now, sulfonylureas are having two disadvantages or drawbacks. They can cause weight gain, and they can produce unpredictable and severe hypoglycemia. In such a situation, you can always substitute sulfonylureas with DPP4 inhibitors. Now, once we start treating the patient with a combination of metformin and a sulfonylurea, suppose the target glycosylated hemoglobin level, that is less than 7%, is not achieved, then I can add pioglitazone as the third drug to the antidiabetic regimen. Now, you have to keep in mind, pioglitazone is contraindicated in patients with heart failure and liver disease. It has the ability to precipitate heart failure and increase the severity of heart failure. At the same time, if you are using pioglitazone, you have to monitor the liver functions in such a patient. And not to forget, it also increases the risk of fractures. So keeping all this in mind, you may introduce pioglitazone. Now, with the combination of metformin, sulfonylurea and pioglitazone, if I am not able to get the required response in the treatment of my patient, then I may supplement this regimen with one of these drugs. It could be a DPP4 inhibitor or an SGLT2 inhibitor, alpha glucosidase inhibitors, bromocriptine, colesevelam, or even GLP-1 receptor agonists. Even if this regimen consisting of 4 or even 5 antidiabetic drugs does not work out, you may include insulin in the antidiabetic regimen. At the same time, continue with the oral antidiabetic agents. Keep in mind not to use pioglitazone with insulin, because this combination increases the risk of heart failure. Now, if certain patients have a near normal fasting plasma glucose levels, they have a prominent or a high postprandial blood glucose levels, you may think of using repaglinide or nataglinide before the meal to control the meal associated glycemia. If the type 2 diabetic on insulin has issues like hypoglycemia and weight gain with the insulin preparations, you can think of substituting the insulin preparations with GLP-1 receptor agonists. So we may try various combinations, and ultimately we have to try our best to obtain the target glycosylated hemoglobin levels in type 2 diabetics, for the simple reason that the level of glycemic control is proportional to the protection afforded against not only microvascular complications but also the short-term complications of diabetes, like non-ketotic hyperosmolar coma and even sometimes ketoacidosis. So this is a flowchart which will tell us the approach towards a patient of type 2 diabetes. So you have to assess the glycosylated hemoglobin, and that is going to tell you the average plasma glucose levels for the past 2 to 3 months. Educate the patient with reference to diabetes, and dietary intervention is very important. Physical activity is mandatory. 20 minutes of moderate physical activity a day, which amounts to almost 150 minutes per week is mandatory. Start the patient on metformin in the absence of contraindications, and if the patient tolerates metformin, well and fine. At the same time, screen the patient for diabetic complications, fundoscopy, urine examination for albumin, and the neuropathy examination. Do a vascular evaluation also. Treat the comorbidities like dyslipidemia, hypertension, obesity, and cardiovascular disease. After assessing the glycosylated hemoglobin, you may take a call. If required, you may add a second agent. Reassess glycosylated hemoglobin after some time. If required, add the third agent. If this combination doesn't produce the required benefit, you may introduce insulin in the treatment. Continue with the oral antidiabetics. Keep on assessing the glycosylated hemoglobin levels and do the necessary changes. And never forget, dietary intervention and physical activity are the other two cornerstones in the treatment of type 2 diabetics. When should we introduce insulin in the antidiabetic regimen in type 2 diabetics? First and foremost, whenever there is an inadequate response to the oral antidiabetic regimen which we are using in our patients, we may have to introduce insulin. And not to forget the stressful conditions and presence of complications. Stressful conditions like infection, trauma, surgical procedures, stroke, pancreatitis, pregnancy, and even labor. These are the stressful conditions where we have to introduce insulin in the antidiabetic regimen in type 2 diabetics. And presence of complications is also an indication to introduce insulin. Complications could be the microvascular and macrovascular complications of diabetes, and also the acute complications of diabetes, which may be non-ketotic hyperosmolar coma, ketoacidosis, or even a history of such emergencies in the past. So these are the conditions, situations where it is mandatory to introduce insulin in the treatment of type 2 diabetics. Thank you very much and happy reading.